My name is Peter Learn. I'm billeted at USUS, but I act as the NISQIP champion at Walter Reed, and I'm the NCR representative to the NISQIP steering committee. So this talk was originally supposed to be given by Rob Rush, and it's maybe a little telling about our some of our challenges that two of the major organizers for the symposium are deployed right now. So hopefully I'll do him justice. He's a very emphatic supporter of NISQIP. And I think most of us who are working with the program agree with him. He's just really good at communicating his emotion about it. So let's see here. So typical disclosures and disclaimers. No one cares about my opinions that much. So let's see here. So I think about our collaborative process right now as stages of evolution. I think you have already heard from some folks who are on the right side of that, where they are highly evolved beings who are really making the collaborative an effective mechanism for change and improvement for patients. So I'm going to talk about kind of how we started out on the left side of this and how we're hopefully moving towards the right side. So let's start with our initial state. So NISQIP has been in the DOD for quite a few years now. The pilot program came out in 2004 after VASQIP was really showing its value and NISQIP was being developed by the ACS. And we had three larger facilities that participated in it. Again, interesting sign of the times that only one of these is still named the same name anymore. And it was demonstrated to be a pretty useful program in those three facilities. They liked what they were seeing, so they wanted to go ahead and expand that. And so in 2009, they expanded to 14 more facilities, and so we had a total of 17 facilities. And the collaborative was technically created with that major expansion to 17 facilities, but I'll tell you that as a self-actualized entity, I'm not sure that the collaborative was really doing a whole lot. There was meetings that they were holding at the NISQIP annual meeting. There were some discussions between people who were at the different programs, but it didn't necessarily have a very solid structure for true collaboration. So a bit of a existential crisis hit us in terms of surgical quality in the DOD. The most public was with the New York Times, and some of you may have recalled that we had a few articles that came out in 2014 and 2015 that were fairly critical of the type of care we're providing. And to be fair, there was a lot of actual relevant criticism in those articles, but it was tough news to hear, especially as a provider in that system. What you didn't necessarily hear about in quite the same magnitude was the military health system review. And this actually was developed before any of those articles came out. And at the time, Secretary of Defense Chuck Hagel commissioned a review of the services we were providing. For our VA partners, it was kind of in the context of all of the negative press that the VA was getting at the time. So he said, well, let's make sure that the DOD is doing okay. And this was due in 90 days. It brought in a lot of external experts to look at our information that we had and provide recommendations. And there were a few key findings of what a lot of us now call the 90-day review. Basically, they found that the direct care component is generally comparable to civilian facilities, which isn't necessarily glowing praise. It says we're doing about average for the rest of the nation. But we did clearly have performance outliers. Some of those were outliers toward the better, but a lot of them were outliers toward the worse. And so the recommendations for action from that were to expand collaboration with external healthcare organizations to improve as a learning organization, and toward that end, identify the causes of variance for MTFs that are outliers, and then continue to develop common standards and processes designed to improve outcomes across the enterprise. And I think what you've already heard today are examples of that type of effort in motion in other collaboratives. So now we needed to evolve a little bit more. We got a little digging tool there. And as we had started out with 17 facilities, this is a map of our 45 facilities that are inpatient facilities across the MHS. And you can see a lot of them are not in the continental United States. So as of 2014, we had 17 of these 45 facilities participating in the NISQIP program. And as of today, we actually have all but 3 sites that are fully operational with NISQIP and collecting data. 3 of those sites are awaiting hiring of individuals. Basically, the nurse case reviewer is still pending. And 2 of those facilities are overseas, and that's part of our challenge in terms of a hiring action, is finding civilians overseas who are interested in working with us. And then in terms of what we do as a collaborative now is driven primarily by this expansion, but we have a bi-weekly telecon from the steering committee that is working on the expansion. And the collaborative as a whole, all the surgeon champions and nurse case reviewers are on a bi-monthly telephone conference. Getting to meet in person is a challenge when we're trying to bring people over from Yokota, Japan and Launchstool, Germany. But we have had a few collaborative meetings, and some of them are at annual NISQIP meetings. But I'm also going to point out how some of our partnerships are bearing fruit to help us make more use of this NISQIP data. So one of those other partnerships a lot of you may have already heard about by now is the MHS Strategic Partnership with the American College of Surgeons. And this was a high-level agreement between the American College of Surgeons and then Assistant Secretary of Defense for Health Affairs, Woodson. And this has led to sponsorship of meetings that have been very NISQIP-oriented. So in May of 2016, we had an in-person meeting in Chicago, Surgeons Leading Quality, which is a course developed by the ACS, and that was focused primarily on NISQIP champions. We had a NISQIP meeting breakout that was a half-day, again, geared towards DOD-specific NISQIP issues. We expanded a little bit in January of 2017 to what we called the Surgical Quality Consortium, because we realized that we also have a lot of outpatient surgery centers that are not included in NISQIP. And so in order to bring them into the fold and make sure that any improvements that we were making for inpatient facilities could also be shared with outpatient facilities, we kind of expanded the group of involved individuals, and that's what forms this Surgical Quality Consortium. And then we'll have another half-day breakout session at what is now being called the ACS Quality and Safety Meeting, which used to be the NISQIP meeting this July. And we've established a site visit program. 3 of the facilities that we've visited 3 facilities so far. Walter Reed was the prototypic facility. We then went to Naval Hospital Pendleton, and then after that, Madigan in Tacoma, Washington. And really, those 3 visits have started to build an idea about what those visits should look like. It's very much a pilot program. We haven't fully sorted out exactly what those visits need to look like, but I am going to probably tackle some folks on this stage before they leave so I can bend their ear about that. And it's brought in some civilian expertise. So we actually have people from the ACS who are involved with doing some of these site visits, who are bringing some of their own experience from their own NISQIP programs and their own successes to assist us in this endeavor. They've also been faculty at a lot of these breakout meetings. One of our other partnerships that a lot of you may have heard of is with the Institute for Healthcare Improvement. And in 2016, the MHS entered into an agreement with IHI. The IHI approach basically is this idea of rapid PDSA cycles. You do small tests of change, and eventually when you think you've got a process figured out, then you expand it to try to fix a problem. And the nice part about that is it gives a bunch of people who don't know a whole lot about quality improvement a framework to work with. And that is where a lot of us stand. Most of our NISQIP champions do not have an extensive background in quality. Frankly, prior to a couple of years ago, I did not have an extensive background in quality. So the MHS is still very nascent, I think, in developing that surgical quality expertise among surgeons. 2 areas that were targeted were access to primary care and surgical quality, so we're 1/2 of the total program. And most facilities in surgical quality are actually using their data from NISQIP in order to drive these, this partnership. So we have these 3 organizations that we've entered into partnerships with. We have our little MTFs in the middle of those. And honestly, it's been a lot to deal with in a very short amount of time. There was a burning platform kind of sense made by the 90-day review. And so we've entered quickly into these partnerships, and we're still working out what's the best way to make them all work together. But NISQIP is probably going to be here to stay. We have a lot of barriers and challenges that we face in our development of this NISQIP collaborative. Centrally, rapid expansion. To quote a different former Secretary of Defense, or paraphrase a former Secretary of Defense, we don't really know what we don't know, so we are actively learning about all the issues that we're going to have to deal with as we expand out to this many facilities. We have problems with service silos, so you have BUMED, you have MedCom, you have AFMOA, all individually giving directives to their hospitals about what they're supposed to be doing and not really talking that well to each other. And we need to start breaking down those silos, and probably the NDAA is going to play a significant role in that, which you heard about earlier with Admiral Bono. Return on investment is a big issue. So the estimated cost for rolling out the NISQIP program to all the facilities annually is a little over $1 million. And you can imagine that when you start talking about figures like that, you do need to be able to show that it's worth it. That includes the cost of enrollment at each facility as well as the hiring of civilian SCRs. Doesn't account at all for the personal costs on the surgeon champions, and we certainly aren't getting paid any extra for it. So, in terms of the data, we need to free up this data more. So everybody, especially prior to 2014, everybody had their data and they kind of looked at their data and they didn't really talk about it with anybody else. And now everybody who's in the collaborative has access to everybody else's data, so we can get a better sense for how our own facilities are doing relative to the rest of the collaborative. And it makes sense to compare yourself against facilities that are treating essentially a similar patient population, particularly when it comes to active duty personnel. For those of you who don't know, we already are doing some public reporting. So on the health.mil website, it's not easy to get to, which is probably the biggest knock against it. But if you can eventually get to it, it'll actually show right now whether we're performing as expected or whether we need improvement or whether we're exemplary for the outcome of morbidity. So right now it's been a very controlled amount of information that we've put out there, but the information is out there. And so facilities that are being labeled as needs improvement in the NISQIP program have a little bit more scrutiny on them as a result of this kind of public reporting. As expected is a very broad category. For those of you who are familiar with NISQIP, there's 10 deciles that you get put into, and as expected covers the 2nd to the 9th decile. So it doesn't necessarily mean that you're knocking the ball out of the park. You could actually be doing just barely above needs improvement and still be as expected. And a big issue for us is how do we translate these results to leadership? A lot of people are looking at NISQIP as, okay, good, this is a way that we can judge hospitals and even maybe adjust their payment scheme. That idea has certainly been floated within the MHS. And are we going to go to them with dashboards? Are we going to go to them with heat maps? How are we going to try to translate this? I think what most people who work with NISQIP would agree is a very complex method of risk adjustment, kind of constant fluctuations in what your outcomes look like. It's not always easy to simplify it in terms of heat maps. Locally, we have turnover of surgeon champions. That's a huge problem. We all know that turnover in general in our system is a huge problem. And so how do you train up someone to become an effective surgeon champion only to watch them move away? So that's something that we are trying to figure out. How do we get people trained quickly so that the time that they are there, they can be as impactful as possible? Hiring freezes, remote locations, and other civilian hiring issues are impairing our efforts in some ways, although, as I pointed out, 42 of 45 facilities are fully operational now. Competing activities, by having these other collaborations, we do have some folks who aren't working with their NISQIP data in their IHI collaboration, so now we're taking the workhorses who are working on surgical quality and we're kind of spreading them a little thin. And for us, and I think even for the ACS, there's this question about how do we most effectively use data from small rural hospitals. And a lot of those hospitals that we expanded into are in that small rural program. It's a very specific program under NISQIP. The nice thing for those hospitals is almost every case that they do is going to get abstracted into the system. So they will actually have a 100% view of what they're doing versus 10% like we have at most of the major medical centers. The downside is we don't fully know exactly how we use that data to best effect. We want to avoid making individuals who may be the only person performing that, operations at a facility, not necessarily feel like all of the weight of the success of NISQIP at their facility is really on their shoulders. So we need to figure out how to make it a growing experience for everybody involved. So those are the challenges ahead of us as we try to move over into the longer stick carrying hominid. We think about what our successes are so far. So we've got 2 facilities. Admiral Bono talked about this earlier as well. Eisenhower Army Medical Center and David Grant Air Force Medical Center were both recognized by ACS NISQIP for meritorious outcomes. Those are great things that we want to be able to advertise, and we also want to see how many more of our medical centers we can get into that group. IHI collaboration is bearing fruits for a lot of facilities in their utilization of NISQIP data. It's allowed them to be much more actionable with the data that they have. And the collaborative meetings, we're getting very good feedback on those. We aren't quite at a point where we're seeing a lot of metrics move yet, so this feedback about what people think of the meetings themselves is very important to us as we continue to develop what the content of those meetings are. And then we are starting to see agreement on common goals. What are initiatives that we want to do as a collaborative that can start making differences at individual facilities? So, and we are starting to see some movement, and this data, unfortunately, it's a heat map, and I don't really like heat maps, but it does get across a couple of points for us here. All those gray bars that you see were facilities that were not participating in NISQIP up until recently. And so what you see on the right side there is that just about every single facility is participating. It's not the most up-to-date information. Some of the facilities that have just started collecting are not included. So we are now becoming much more accountable for our surgical outcomes. And if you are going out into the surgical workforce in the military, you are going to be at a NISQIP participating hospital, which is nice because you'll be able to find the NISQIP champion and ask them how you're doing as an individual surgeon, or you may become the NISQIP champion. The red dots are important too. Those are the areas where we score it as needs improvement. Now, again, on a single report, having a needs improvement is not always informative to represent merely as a red square. But what we do see is that a lot of our hospitals that were participating a couple of years ago have decreased the number of red squares that they have. So the hospitals themselves are starting to learn how to use this data better. And I think a lot of that has to do with the collaborations that have already started to occur, the mentorships that have already started within the DOD. But as you can see, we still have some work to do. And when we bring new facilities online, boom, that's the first time we know anything about how they're doing. And we just have to figure out, okay, how do we start improving from there? So in terms of our future directions, I think the Surgical Quality Consortium will be important to help support the collaborative because it's going to be the pathway to governance. Anytime you want to do something and force a medical facility to do it, you need to run it up through a chain of command. And this is actually part of the chain of command for making things happen in the MHS. Development of a DOD Surgeon Champion Handbook. Again, if we have a problem with Surgeon Champion turnover and we need to get people up to speed quickly, we probably need to tailor the education of Surgeon Champions a little bit more to dealing with the DOD. One of the common goals we've talked about is developing a basic surgical safety checklist, and as Cerner is rolling out, we're finding out that someone has already decided what our surgery checklist should look like without actually consulting with any of the people who are directly involved with making a checklist at their facilities. And as you've also heard from the other speakers on the dais here, us getting involved is so critical to making sure that people don't just go off in a very wrong direction when it comes to surgical quality. We are working to expand our site visit program. In fact, in the next few weeks, I have to make the case for why we need the money to be able to continue to support the site visits. And I think when you start gathering this much data, clinical investigations definitely become a reality for what our collaborative could be able to do. And then data visualization. We've got to figure out what's the best way that we can present this data to leadership so they can get the answers on returns on investment without necessarily becoming obsessed with red squares versus green squares. And so this is, again, the dots that you saw that Admiral Bono showed earlier. I think how we're really going to show that we are effective as a collaborative is if we can take those dots and start moving all of them towards the lower deciles. You can see that we have a lot of spread right now. Fortunately, the mass seems to be above a 5th decile or above, but we have plenty of folks below the 5th decile. So we really want to see if we can make that happen and show some of these dots starting to move towards the left. And that's when I think we will be closer to becoming this fully evolved man. Special thanks to Robert Rush, who I think has been a major driver for the NISQIP collaborative. For those of you who know him, he is a very motivating person. Molly Mullen, who was around at the beginning from when NISQIP started in the DOD, Captain Rutino and Lindsay Bauer, who helped give us support for the actual collaborative aspects of it, and the other members of committees that are influencing our progress.